Hello everyone, welcome back to my YouTube channel. My name is Dr. Hamid and our today's topic of discussion is multiple myeloma. Very important topic and very interesting topic for the preparation of step 1 and step 2. They ask a lot of questions related to this topic, so I would highly recommend making good concept on these important topics, and multiple myeloma is one of them. Okay, so what is multiple myeloma? What is the definition? Basically, it is the malignancy of plasma cells. Now, what are plasma cells? I'm taking you to the basic. First, we know that hematopoietic stem cells, undergo two lineages. The first is lymphoid and the other is myeloid. By the way, I'm using first aid, USMLE step 1. Okay, and so hematopoietic stem cells either undergo into the lymphoid side or the myeloid side, and they become B lymphocytes, T lymphocytes, and natural killer cells. Okay, those B lymphocytes, some of those B lymphocytes become plasma cells, and plasma cells are those cells that produce immunoglobulin, like immunoglobulin G, A, M, E. These are the types of immunoglobulin. Usually, immunoglobulins are polyclonal. In multiple myeloma, it is a malignancy of plasma cells in which the immunoglobulins are monoclonal. So there is excessive production of monoclonal immunoglobulins. Okay. And this disease usually affects elderly patients. Okay. Whenever you see the question that is talking about any malignancy or anything related to children, don't think about multiple myeloma. Okay, so age, gender, these are the important things you should see, you should look when you solve your question bank. Okay, so that's why I'm emphasizing that it is the disease of elderly patients. Usually it affects individuals in their seventh decade, usually patients in their 70s, usually in their 60s, 70s, 80s. Okay, this is a disease mostly in the seventh decade. Okay, now, what are the risk factors of multiple myeloma? The first is exposure to radiation. Okay, a lot of malignancies have a risk factor of radiation. Okay, the second risk factor for multiple myeloma is MGUS, monoclonal MGUS. I'm explaining the full form is monoclonal gammopathy of undetermined significance. Okay, monoclonal gammopathy of undetermined significance is similar to multiple myeloma. I'm talking about the risk factor. So AMGUS is the risk factor of multiple myeloma, and it is similar to multiple myeloma, but in AMGUS there are no CRAB findings. We'll talk about it. Okay, so usually AMGUS is an asymptomatic condition, and eventually when it is asymptomatic the patients would not have any symptoms and it is mild condition. So eventually this disease lead to multiple myeloma. So that's why amgus is also the risk factor for multiple myeloma. Okay, now what are the clinical features of multiple myeloma? CRAB is a very important mnemonic, very basic, very important mnemonic. So C for hypercalcemia, R for renal involvement, A for anemia, and B for bone lytic lesions. These are the four major findings we see in multiple myeloma. Let's first talk about hypercalcemia. How we see hypercalcemia in multiple myeloma. So because the tumor because the tumor is infiltrating the bone marrow, when the tumor is infiltrating the bone marrow, there will be um, movement of calcium out of the bone into the blood circulation. So hypercalcemia occurs due to tumor infiltration in the bone marrow. Okay, when multiple myeloma tumor cells infiltrate the bone marrow, it is the reason of hypercalcemia. Second reason of hypercalcemia is that multiple myeloma tumor cells, they secrete osteolytic cytokines. Okay, I'm repeating, multiple myeloma tumor cells secrete osteolytic cytokines. Example, tumor necrosis factor alpha. And these osteolytic cytokines, what they do, they liberate calcium from the bone and result in hypercalcemia. Okay, So these are the two reasons of hypercalcemia in multiple myeloma. First is the tumor infiltration in the bone marrow. The second is these tumor cells in the bone marrow release osteolytic enzymes. So these osteolytic cytokines cause the breakdown of the bone and release calcium into the circulation. So these are the two reasons of hypercalcemia. Okay. Now I want to go deep into it so that we can talk about rank L. Okay, so because I want you to be very clear about hypercalcemia. Okay, when there is hypercalcemia, so we have talked about the two reasons of hypercalcemia in multiple myeloma. Whenever there is increased serum calcium, we know that it inhibits parathyroid hormone release. So in multiple myeloma, the serum calcium is high, so there will be decreased release of parathyroid hormone from the parathyroid gland. Low parathyroid hormone decrease calcium absorption from the renal tubules, hence lead to hypercalciuria. So in multiple myeloma, first we'll see hypercalcemia, and for more understanding, we'll see hypercalciuria because of decreased parathyroid hormone level that is not contributing to absorption of calcium from the renal tubules. Okay. Third is there will be decreased 125 hydroxy vitamin D3 level, which is the active form of vitamin D in multiple myeloma. Why? And again, because of the increased serum calcium, there will be low parathyroid hormone released from the parathyroid gland. And when there is a low parathyroid hormone, it reduces the activation of 1 alpha hydroxylase enzyme in the renal tubules that converts 25 hydroxy vitamin D to 125 hydroxy vitamin D. So that lead to decrease 125 hydroxy vitamin D3 level. So in a nutshell, in multiple myeloma, first we are seeing hypercalcemia. And due to hypercalcemia, we are also seeing hypercalciuria, and we are also seeing decrease 1 to 125 hydroxy vitamin D3 level. Okay. Now, second is renal involvement. Why renal involvement would be there? Because of these monoclonal paraproteins, these immunoglobulins, they enter into the renal tubule and then they crystallize there and lead to cause renal insufficiency. Okay, they in a simple words, they cause crystalline nephropathy in due to multiple myeloma cancer cells. Okay. Third is anemia. We'll see a normocytic anemia in multiple myeloma. Okay. And then we'll see a bone lytic lesions. These are punched out lesions on the X-ray. Okay. Now, bone lytic lesions, why there is an osteolytic or osteoclastic activity in multiple myeloma. Okay. We have already talked about that in multiple myeloma cancer cells, they replicate in the bone marrow and they produce certain cytokines that stimulate osteoclastic activity and inhibits osteoblastic activity that leads to generation of purely osteolytic lesions. Okay, here I want to share a very important diagram with you all, very important for good concepts. This osteoclastic differentiation on the left side of the screen. So what happens is usually there is a balance between osteoblastic and osteoclastic activity in the bone marrow. Okay, for and we are seeing here in multiple myeloma that there is more osteoclastic activity than osteoblastic activity. Okay, for your understanding and to make things very simple, I would say that you should remember, always remember that there is a protein or an certain kind of a protein, just remember it like that way, which is called osteoprotagrin osteoprotagrin, and that protein is the one that inhibits osteoclastic activity. Okay. And rank is the one that promotes osteoclastic activity, that promotes osteolysis. Okay, so look at this diagram. This is an osteoblast cell in the bone marrow. These are osteocytes or osteoblast cells in the bone marrow. Okay, and this osteoblast, um, look at these. This cell has rank L. What is rank L? Receptor activated nuclear kappa ligand, something like that. Okay, receptor activator of nuclear factor kappa b ligand. Okay, so this rank L is present on the surface of these osteocytes. Now rank and osteoprotagrin will decide whether these osteocytes will undergo osteoblastic activity or osteoclastic activity. Okay, I'm repeating again, these are the osteocytes and they have certain projections called rank L. Now, rank and osteoprotagrin will decide whether the cell will go osteoblastic bone formation activity or osteoclastic bone lytic activity. Okay, so when rank binds to rank L, there will be osteoclastic activity, there will be lysis of bone. And when osteoprotagrin covers that rank L and prevent the binding of rank to rank L, there will be no osteoclastic activity. So in a very simple words, this osteoprotagrin is the protein, something that is inhibiting osteoclastic activity. And when we have high osteoprotagrin to rank L ratio, there will be decreased osteoclastic activity. Okay. And when there is a low osteoprotagrin to rank L ratio, there will be increased osteoclastic activity. So this diagram is very important. If you will remember osteoprotagrin that is inhibiting osteoclastic activity, you will remember the rest of it. Okay. Now let's talk about what are the tests we do in multiple myeloma. What are the important tests we do to diagnose multiple myeloma? Okay. First, and the very important test, the best initial test for the diagnosis of multiple myeloma, excuse me, and they usually ask a lot of questions on best initial test. The best initial test is serum protein electrophoresis. Okay, we'll do serum protein electrophoresis is the best initial test to diagnose multiple myeloma, and that shows IgG or IgA monoclonal spikes. So this on the screen left, you see below plasma cell disorders, you see M spike here. These are monoclonal spike, usually on showing IgG or IgA monoclonal spikes. Okay, so this is serum protein electrophoresis, which is the best initial test. What is the most accurate test to diagnose multiple myeloma? So we do bone marrow biopsy is the most accurate test, and that shows more than 10% monoclonal plasma cells. Okay, now let's talk about what the bone marrow, when we do the bone marrow biopsy and that bone marrow biopsy shows more than 10% monoclonal plasma cells, how they look, how the monoclonal plasma cells look. Now I'm gonna share very high yield diagrams with you now, very very important. Okay, so yeah, let's this C, image C, this is what you see when you take a bone marrow biopsy that shows more than 10% monoclonal plasma cells. So what you see, this C image, okay, let me zoom in this for you. Yeah, this. So what you will see here is a plasma cells that has clock phase chromatin, very important. Okay, you will see More than 10% of the monoclonal plasma cells. There are a lot of plasma cells, okay? And you will see clock phase chromatin. You will see eccentric nucleus, okay? How you will appreciate that this is multiple myeloma. A lot of times they give you this particular image. Yeah, I have seen this. They give you this image, obviously with nothing is written there. They give you this image and they ask you about the diagnosis, and it's very simple. It's multiple myeloma. You see more than 10% of the monoclonal cells. You see clock phase chromatin. You'll see eccentric nucleus would not be in the center. And you'll see perinuclear clearing. These are Golgi apparatus. You see abundant basophilic cytoplasm. Okay, so this is what you see in a bone marrow biopsy of multiple myeloma. Okay, now we have talked about the best initial test. We have talked about the most accurate test. Now, what are the other tests we do when we do a CBC, complete blood count? What we see, a Rolex formation. This is the stack of RBCs. Look, like a poker chips. You see here this image B. Okay, so stacks of RBCs in this complete blood count. And this image A, this is showing osteolytic, pure osteolytic lesions. This black holes. Okay, these are osteolytic lesions. This is the skull, okay, by the way, and they're showing osteolytic lesions. Okay, and what other test we do? We do urine protein electrophoresis, but serum protein electrophoresis is the best initial test, not urine protein electrophoresis. We do urine protein electrophoresis, but it's like a very, it's not something they'll ask you a lot. Okay, and in urine protein electrophoresis, we see Bence-Jones protein, and one again, very important thing they usually ask in the question stem, you'll see a gamma gap. What is gamma gap? So we have talked about best initial test, most accurate test. Other tests are complete blood count, urine protein electrophoresis, and now we are talking about gamma gap. Now, what is gamma gap? Gamma gap is serum total protein, the total serum protein minus serum albumin. Okay, when we take the difference of total serum protein and serum albumin, and the difference is, if that difference is 4 or more grams per deciliter, this is pointing towards multiple myeloma. So to why am I emphasizing on gamma gap? Because when I was preparing for step 2, I've seen a lot of questions that are confused between um, they try to confuse you with between multiple myeloma, MGUS, and Waldenstrom macroglobulinemia. We'll talk about that in the upcoming lectures. Okay, so um, a lot of times what happens is when you calculate gamma gap, this will help you to come to the conclusion that what is the diagnosis. So when you check the gamma gap, what is gamma gap? Serum total protein minus serum albumin, and if that gamma gap is 4 or more grams per deciliter, it is multiple myeloma. Okay, due to the presence of large amounts of monoclonal protein, we see a gamma gap. Okay, now, yeah, I think I've talked everything related to multiple myeloma. And yeah, they usually a lot of times they ask about the complications. So the complications are, there are two main complications. The first is increased risk of infection. Why there is an increased risk of infection? Because of the monoclonal immunoglobulins that are usually ineffective. They usually don't perform their function well, so that increases the risk of infection. And primary amyloidosis or AL amyloidosis we also seen because of multiple myeloma. And we'll talk about amyloidosis in the next or upcoming lectures. I don't know when, but we will talk about amyloidosis very soon. Now, the treatment option, we give patient proteasome inhibitors, like the names are very difficult: bortezomib, zomib, okay, bortezomib, ixazomib, or the carfilzomib. You can search these names in the first aid, they are there. Okay, so how they perform their function, how they are used to treat multiple myeloma. Bortezomib is a very important one, you should remember. Okay, so what they do, they facilitate apoptosis of the neoplastic cells. Okay, how they facilitate the apoptosis of neoplastic cells? They promote apoptosis of neoplastic cells by preventing degradation of pro-apoptotic factors. So they prevent these proteasome inhibitors, bortezomib, ixazomib. They prevent the degradation of pro-apoptotic factors. They call these pro-apoptotic factors to remain there, to not undergo degradation, to stay there and then kill those neoplastic cells. Okay, this is how they treat. They get rid of multiple myeloma tumor cells. Okay, I think I have talked everything about multiple myeloma. Very important topic. If you guys have any questions, you can ask me in the comment section. Thank you so much.